lecture in the COVID and Society series. Today it's Monday, and I'm happy to announce to you that we have Gera Nagelhout, a professor in Maastricht University, and she also works at the EVO Research Institute, which is an institute for research to addiction, people who are addicted. I have to announce that tomorrow the seminar about the Lesbos and the refugees in Greece is suspended until Thursday, the 28th. So tomorrow there will be no seminar. That will be on the 28th of May. So now I would like to introduce to you Gera, who will talk about socio-economic differences and the COVID pandemic.
Okay, thank you very much, Roos, for the introduction. My talk today is about socioeconomic differences, health and addiction during the corona pandemic. I am a professor at EVO Research Institute and Maastricht University. And my research focus is on socioeconomic differences, addictive behaviors, health and well-being, and people in vulnerable positions. So a few months ago, the COVID-19 pandemic started, and I was immediately thinking, what would be the impact of this pandemic on socioeconomic differences, addictive behaviors, people in vulnerable positions, and health and well-being. Of course, because this is my research focus, I was immediately thinking about what the impact would be of this pandemic. Today, during the lecture, I will talk to you about things that I already could find about changes that we are already seeing. But for me, it's a little bit a different lecture than normal. For one, because it's online, and second, because I'm also telling you about fears and concerns that we have for certain populations, and not only evidence that we have, because it's still developing, and of course we will know in 10 years what the exact impact on socioeconomic differences will be, and not already. In this lecture, I will start with an introduction to socioeconomic differences in health, because most of people who participate right now are students, medicine students from Utrecht University, and some others are just interested in the talk and also join us. So perhaps for the others as well, it's good to have a little bit of an introduction to socioeconomic differences in health before I start with the possible impact of the pandemic on these topics, on socioeconomic differences and also addiction. I have divided this in 3 parts. First is the disease, then comes the measures, and finally the economy. And finally, I will end with some final remarks and also with time for questions, of course. First, I have some questions for you. If you could go to menti.com and use the code 135245, then you can answer just a few quick questions to know who's in the room and who's joining this webinar, and what your thoughts are about this topic. You can also use the QR code, but then you have to be fast before I go to the next slide. So you can make a picture of the QR code to go to menti.com automatically, or you can type in on your phone or on your computer menti.com and use the code 135245. I have a few quick questions for you. The first one is, from which country are you? And I see that you are already used to using menti.com, so 30 of you have already filled in the first question. So I see a lot of people from the Netherlands, and some have spelled it in Dutch, and some have said de before Netherlands. And we also have people from Russia, Belgium, and Suriname. And I have 40 answers right now. So I am from the Netherlands myself. most of the talk, I will try also to include more a worldview of what is happening and not only focus on the Netherlands, but of course, I know most about where I'm from. So it'll focus a bit on the Western world, I guess, and the Caribbean. Most of you are from the Netherlands. North Korea, okay. Well, it's very good to have such a diverse company here. Already 50 answers. I think about 70 of you are here, so I'll wait for a few minutes. Okay. I'm not sure whether
I think
everyone, yeah, maybe I'll go further. I don't know if everyone uses Mentimeter or is just watching. And if you're joining later with Mentimeter, you can also join in with a second question. That's no problem. Couple more. Okay, very good. The second question is whether you are a student, perhaps a researcher, because colleagues of mine or people from my LinkedIn might have joined, other professional, or just someone who's interested. And I see that most of you are the students, probably from Utrecht University, because it's part of your course. And we are almost to 60, yes. Okay, and then finally, the last question for now. Do you agree or disagree with the question or the statement, the consequences of corona are the same for everyone, rich or poor? And a lot of you disagree with this. Yeah, well, quite clear that you already know something about this topic. Maybe others of this lecture series have already told you a little bit about this, or you're just assuming this because of the topic of my talk. Okay, I agree with you that I also disagree to this statement, but I will explain why during this talk. So first, let me introduce socioeconomic differences in health. Socioeconomic position is the social standing or social class of an individual or a group, and it is often measured as a combination of education, income, or occupation. And someone with a lower socioeconomic position, so that's someone, for example, with a lower education or lower income, they may have less well health. So lower socioeconomic position is associated with higher levels of obesity, higher rates of tobacco use, higher rates of chronic diseases, depression, social problems, chronic stress, and many more things. And this results in less healthy life years and also in shorter lives of people with a lower socioeconomic position. There are socioeconomic differences between countries. And you can see here, for example, the average life expectancy at birth. In high-income countries, it is higher than in low-income countries. So in high-income countries, the average life expectancy at birth is 81 years, while it is 63 years in low-income countries. So that's quite a large difference. But there are also socioeconomic differences within countries. And I'm now showing you an example of the Netherlands. But the pattern is the same in other countries. People with a high educational level have a higher average life expectancy at birth than people with a lower educational level. And also people with a higher educational level have a higher life expectancy without physical limitations than people with lower education. And you can see even more differences in this green bar about life expectancy without physical limitations. An explanation for this is the social determinants of health. So health is determined not only by whether you go to a doctor or whether you choose to live healthily, Health is determined by a combination of personal characteristics and circumstances in which people are born, grow up, live and work. So for example, the economic stability of not only the country, but also the household. Whether you have a job and how much money you get, whether you get social welfare. The social and community context where you live is also a large influence on your health. The neighborhood and the environment, so the environment around you is influencing your health. Then the quality and availability of healthcare, and finally also education. So these are things that determine health, and they are also very much related to socioeconomic differences. A recent theory explains what scarcity or having too little does to your brain. It's a recent theory from 2013 by an economist and a psychologist. And they explain that if you have scarcity, so for example, a lack of money or debts, then that uses all your mental energy. And it creates a kind of tunnel vision where you only focus on meeting your unmet needs and not focus on other important decisions. This depletes your self-control, and it makes sure that you are going to myopic decision making, which is a very difficult word, for short-term thinking. So the fact that you're so obsessed with having scarcity of money makes sure that you cannot make very good decisions about health behaviors, for example. Unfortunately, health behaviors and poverty or having too little money are not something that happens in only one generation. There are intergenerational patterns, and this model shows the health poverty trap, which is one of the explanations. And it says if you're ill and poor, then you have a choice. You can seek healthcare or you could not seek healthcare. If you seek healthcare, this costs money. But if you do not seek healthcare, then you remain ill, and that also costs money in the end because you cannot work. So this will mean either way that you have less income, and then you can buy less healthy food, and you cannot invest in education. So this ensures that your children also remain poor and then have a higher probability of illness. That's why they will also can also be ill and poor. So then this keeps happening. So that's an explanation of intergenerational patterns in poverty and health. To give a somewhat more concrete example of socioeconomic differences, I'm showing you something about tobacco use. People with a lower socioeconomic position have a larger chance of smoking tobacco. And this has a lot of different causes, and you can see them. It's a very busy model with a lot of influences. But the lower socioeconomic position ensures that people live in a social environment where a lot of people smoke. So they are under the social influence of others that they see smoking, and they think it's normal to start smoking. So they start smoking early, for example, which makes them more addicted and less likely to stop smoking. Also, because of their lower socioeconomic position, they have less money, which ensures that they cannot buy smoking cessation treatment, and therefore they are less successful in smoking cessation. And their lower socioeconomic position also causes them to have stressors in their lives, like I said a while back about scarcity. Because of these stressors, and also because of the social environment where a lot of people smoke, they have lower self-efficacy to quit smoking, and also lower self-control to quit smoking. So you can see that especially the social environment that smokes is a large influence here. And therefore the difference between people with a higher and lower socioeconomic position in smoking remains from generation to generation. So that was the short introduction about socioeconomic differences in health. And now I will be talking about the COVID-19 pandemic. I've divided it into 3 parts: the disease, the measures, and the economy. But of course, it's not that strict that you can really say, well, this is part of the disease and this is part of the measures, but I've tried to make a distinction. First, I'm showing you a short movie clip.
They tell us coronavirus is a great leveller. It's not. It's much, much harder if you're poor. How do we stop it making social inequality even greater? Hello, good evening. The language around COVID-19 has sometimes felt trite and misleading. You do not survive the illness through fortitude and strength of character, whatever the Prime Minister's colleagues will tell us. And the disease is not a great leveller, the consequences of which everyone, rich or poor, suffers the same. This is a myth which needs debunking. Those serving on the front line right now, bus drivers and shelf stackers, nurses, care home workers, hospital staff and shopkeepers, are disproportionately the lower paid members of our workforce. They are more likely to catch the disease because they are more exposed. Those who live in tower blocks and small flats will find the lockdown tougher. Those in manual jobs will be unable to work from home. This is a health issue with huge ramifications for social welfare, and it's a welfare issue with huge ramifications for public health. Tonight, as France goes into recession and the World Trade Organization warns the pandemic could provoke the deepest economic downturn of our lifetimes, we ask what kind of social settlement might need to be put in place to stop the inequality becoming even more stark. One of the hardest things about dealing in...
Okay, I think this sums up very nicely what my talk is about. So I wanted to show you this.
Graphs and numbers, statistics.
And now I want to do one more question for you about the possible impacts of the COVID-19 pandemic on socioeconomic differences in health and on addiction and substance use. This is just a brainstorm before I'm telling you things about these possible impacts, bit to trigger your mind of what could be possible impacts, so you can type in short statements of what you think is happening, and you can choose to fill in all three boxes or just one of them. I've also sent the students who are joining us from Utrecht University some literature on alcohol use. So maybe this triggers your mind about what could be the impact on substance use. So I already see some things coming up. Poverty, violence, higher rates of depression, an increase, I think this is about the socioeconomic differences, collateral damage, widening gap, black-white, increased dependence, and now a lot of answers are coming up, more substance use, depression, fear, income, money problems. So you're doing a very good brainstorm right now. Very nice. Because you're all typing in different words now, the words are getting very small. Discrimination, suicide, money problems, depression and poverty, most often mentioned. Okay, thank you for this first brainstorm. More depression, homelessness, larger gap, discrimination. Yes, very good. Okay, well, let me go on with my talk. I will start with the possible impact of COVID-19 on the disease. Even before this pandemic, there were inequalities in vulnerability to infectious disease. This report from 2013 said that there are groups who are subject to multiple social determinants of health that may be particularly vulnerable to infectious disease. And those are the poor and more disadvantaged individuals. They tend to suffer from a higher disease burden and are more likely to experience illness and disability. And of course, this also is the case for this pandemic. What we should keep in mind if and when we find a vaccine for COVID-19 is that some population groups have had poor access to vaccination in the past and also to healthcare systems. So if there is treatment or a vaccine, then we should be careful that some population groups don't have access. And also that alcohol addiction and illicit drug use are strongly associated with poor treatment adherence. So we should help this group even more. Hand washing is something that is, of course, very important, a single most effective way to prevent the spread of infections. I hope you know that already. And 60% of the world population has access to hand washing facilities at their home, just water and soap. But this is much lower in the least developed countries. So 25% of sub-Saharan Africa has basic hand washing facilities at their home, and nearly 3/4 does not, which leaves this group even more vulnerable than they already were. Certain jobs, people with certain jobs are more at risk. It was already told in the BBC Nightlife clip that I showed. Some people who are working in the front line, like nurses, supermarket employees, and bus drivers. They are more exposed to the virus because of their work, and also they have lower paid jobs. An important determinant of disease risk is getting paid sick leave. In the US, nearly half of all workers do not receive paid sick leave. This is very different to the Netherlands, luckily. But among the working population with the lowest income in the US, more than 3/4 receive no paid sick leave. So if you do not get paid when you're sick, you could make the choice to go to work anyway. And then you could spread the disease even further among your co-workers, who probably are also people with a lower income. And then the spread of the disease is more among this group. Research also shows that guaranteed paid sick days would significantly improve public health and reduce the spread of viruses, for example, to the public, for example, in restaurants and nursing homes. And not only in getting the disease, there are differences, but also in the severity of the disease. People with obesity and people who smoke experience more severe COVID-19 disease and more often need to be hospitalized. And in a lot of countries, including the Netherlands, there are large socioeconomic differences in obesity and smoking, which is more common among people with a low socioeconomic position. So this disease makes the difference that is already there even bigger. Also, chronic health conditions, which are also in part due to obesity and smoking, but also due to other determinants, are more prevalent among people with a lower socioeconomic position. And these health conditions make the coronavirus more severe. So then you get socioeconomic differences in death rates, but also among the survivors who've had severe COVID-19 disease and were hospitalized. We don't know the exact health impact of having had severe COVID-19 disease yet, but first results show that people remain having issues with their lungs, for example. So they may get a chronic health condition, and socioeconomic differences will even increase further. Then there are also ethnic differences in COVID-19 cases, and one of you already mentioned this in the brainstorm that we did. In Chicago, for example, 72% of people who died of COVID-19 were Black, but only 1/3 of the population is Black. So that's a large difference. And then in Georgia, white people accounted for 40% of the cases, but they represent 58% of the state. So this is an underrepresentation of people, of white people. And then finally, some numbers from the UK. 35% were non-white, which is much higher than the population of non-white people in UK, which is 14%. So where does this difference come from? It's not biological differences probably between people with different backgrounds, but income inequalities, for example, job insecurity, deprivation, and even the air quality of the living environments of people with different ethnic backgrounds. And you can see in the table that people, the patients with confirmed COVID-19 are mostly from the most deprived populations. So that was the disease, and now the measures, so the lockdowns and the physical distancing. Staying at home is much more tougher if you live in overcrowded housing. This is something that is not happening a lot, or there are not a lot of socioeconomic differences in overcrowding of houses in the Netherlands, but it is happening a lot in other countries. So people who live in smaller houses with more people, they have more difficulty, of course, if they have to stay at home. Yeah, and they cannot go outside. Also, working from home is not possible for everyone. I am a researcher, so I can easily work from home. It's not really a problem. But if you're doing manual work or working in healthcare, then you cannot work from home. And this table shows that people from the top 25% of incomes, 62% of them can work from home, and from the bottom 25% of incomes, only 9% can work from home. Because of the physical distancing and the lockdowns, loneliness increases. And this can increase psychological problems, which is even worse for people who already had existing psychological problems, which is something that is also socioeconomically related. And in some places, I don't know whether that's everywhere in the world, but I think in a lot of places, facilities like daycare activities, food banks and home care have closed or temporarily closed. And that affects people with a lower socioeconomic position even more. People with low literacy, I don't know what you've learned in your education already, so I will explain. People with low literacy are people who need more time to read and listen to information before they can comprehend it. And this is also related to their socioeconomic position. People with low literacy are more likely to be lower educated and have lower incomes, and also are more likely to be poor, for example. The COVID-19 pandemic is very difficult for this group. There is a general information overload, even for us. A lot of people experience that there is a lot of information, but this is even more difficult if you have difficulty reading and listening to this information and comprehending it. There are constant changes in rules and policies, so you have to keep up with the information and to know whether you can go outside, whether you can go in shops and things like that. And there are a lot of difficult words used, more than normally, because we now have COVID-19, pandemic, immunity, and a lot of other difficult words. There are a lot of written signs in shops, much more and in other places, institutions. In the Netherlands, there are no general rules about shops. They can stay open if they want, but they have to make sure that people are not too close to each other. So on each shop, you will see a piece of paper saying, well, in this shop, you can be with maximum 5 people, and in this shop, maximum 6 people. So you will have to read that and see what other things they are saying about how you should behave in this shop, which is very difficult if you have difficulty understanding the signs. And also because of the physical distancing and the lockdowns, people will get reduced help from informal caregivers, for example, with filling out forms. It's also a difficult situation, of course, for people with mental health problems and people in addiction treatment. Many mental health and addiction services are staying open in the Netherlands and also in other countries, or offer their services online. But of course, they struggle with physical distancing and staff sickness. For residents, residential clients, it can be very difficult that they can receive no or less visitors, and sometimes they have to stay inside. This can, of course, lead to increased mental health problems for these clients, and so also sometimes aggression against the staff. There is a large amount of care avoidance for care in general, but also for mental health and addiction care at this moment. I don't know about other countries, but I know in the Netherlands that some places do not have a waiting list anymore, not because people don't have problems anymore, but they're just waiting for the situation to change, and they're afraid to get infected if they go to an institution. So this is a problem, of course, for the people themselves who need this treatment, but there are also large worries about the children of these people who do not get help. Those children are already in a very difficult position because they, living with someone, a parent with mental health problems or addiction can be very difficult, and even more so if this person needs help but doesn't get help. Changes in alcohol and drug use are very dependent on the different population subgroups. Some people use less alcohol and drugs right now, and these are mainly the people who are not very dependent, and they use alcohol and drugs right now less because there is less availability. You cannot go to a bar, for example, or a restaurant. There are less parties, and also people are motivated to live healthily because they don't want to get sick. But there's also an increase in use among people with high stress, anxiety, depression, loneliness, and even boredom, who use alcohol or drugs to cope with these negative emotions. And you can imagine that there are certain groups that are more at risk for this, like people who work in healthcare and are have very stressful lives at this moment, but also people who are already poor or losing their jobs, people who have to juggle working and also caring for their children. So there are a lot of groups who are more at risk. An example of the SARS virus outbreak in 2003, then alcohol use and alcohol dependence increased among healthcare workers who experienced a lot of stress. So who were working on the wards for the SARS virus outbreak. In a lot of countries, the supply of alcohol or drugs is reduced. Sometimes there are measures that say you cannot buy alcohol, for example, or buy it less than normal. And also the drugs routes are more difficult because of lockdowns in certain countries. And there are concerns about people who will get serious withdrawal symptoms or who then choose to use more risky drugs or more risky ways of using drugs because they cannot get the normal drug of choice. The third possible impact of the COVID-19 pandemic on socioeconomic differences and addiction is the economy. There is a large drop in employment. In the first quarter of 2020, we mainly saw this in Asia, of course, where the pandemic started. And in the second quarter, these are projections, we probably will see also a drop, but then over the entire world. There is also a drop in the gross domestic product. These are EU numbers. You see here a timeline from 2008 to 2020 first quarter. and you see a large drop, very large and sudden drop in GDP growth rates in 2020. And you can see that it's more sudden and more severe than the economic recession in 2008. So we cannot speak of an economic recession yet, because you then have to have 2 consecutive quarters of negative GDP growth rates. Yeah, it's already quite clear that we will go into an economic recession in the second quarter of this year. And this has a disproportionate impact on certain subgroups. We think that groups that are particularly vulnerable are people with underlying health conditions and older people, also young persons, because they are just starting on the labor market and maybe cannot find a job or cannot find good social care in their job. Women who are more in occupations at the front line, for example, nursing. Self-employed and casual workers who have less social protection, and migrant workers. There's also a predicted rise in global poverty. This graph shows a projection of the impact of COVID-19 on global poverty. And what the researchers did, they compared projections, or they compared the numbers from April to 2020 to October 2029, and they assumed that the changes between these months were caused by the corona pandemic, and then made a forecast for 2020 and 2021. And these forecasts show an increase in global poverty, and this would be the first increase since 1998. And if you calculate it in numbers, then the COVID-19 pandemic would push 49 million people into extreme poverty in 2020. There's also a figure about regional differences in this rise in poverty. So you see the 49 million people here, and 23 million people from this are from sub-Saharan Africa. This depends on how many people are living close to the poverty line. People from low and middle income countries are often living more close to the poverty line, and therefore they will suffer the greatest consequences in terms of extreme poverty. And sub-Saharan Africa is not the place where the virus has been hitting the most, at least until now. But the projections show that it will be the region hit hardest in terms of increased extreme poverty. So what is the impact of economic recessions on use of substances? A few years ago, I've done a literature review for the European Commission of literature from all over the world. And it's quite a complicated graph, but I'll help you through it. There are a few mechanisms that could explain the impact of economic recessions on substance use. And we were particularly interested in these mechanisms. So the first mechanism is the income reduction mechanism. An economic recession, of course, leads to less income among certain people. And you can imagine if you have less money, then you won't have money to buy tobacco or alcohol, for example. So this could decrease your use. And this is called a pro-cyclical mechanism, and it's shown in green. We do not see this for illegal drug use, probably because people, if they have less money, just turn to cheaper products, for example, or maybe less illegal ways of obtaining income. But we do see that an income reduction leads to less tobacco use and less alcohol use. And then the second mechanism, and this is the most important one because most literature has been found about this, and most literature that shows that this is an important mechanism, is the psychological distress mechanism. So if you remember one thing of this slide, then you should remember this mechanism. An economic recession and also unemployment leads to more psychological distress among people. And if people have more stress, then they tend to use more illegal drugs, more tobacco, and more alcohol. Because this was the most important mechanism, you often see an increase in these substances during an economic recession. Other mechanisms are that people have more time for substance use, which could increase illegal drug use. And they would have more time for treatment, so this could decrease tobacco use, but not much research has been done on this mechanism, so we don't know for sure. And also people who are unemployed may feel socially excluded, and this could increase their drug use and also their alcohol use. So these are things that could happen during an economic recession and have happened in the past. And because we expect an economic recession after or during this crisis, we will probably see these things happening, and probably will mainly see an increase in use of these substances due to the psychological distress mechanism, although we could see a little bit less tobacco or alcohol use because people have less money. Some final remarks that I want to close with. I've shown a lot of negative things during this lecture and a lot of worries and fears and concerns. So I want to end a bit more positive. So some positive notes are that many governments are working on income support policies and policies that are meant to prevent a rise in unemployment. So this is of course a good thing. Mental health and addiction services are also working very hard to improve their services despite the circumstances, and they are continuously learning on how to still maintain their services despite what's happening. And one thing that I see, and I don't know whether others also notice it because I'm a bit more focused on this topic, of course, is that there is a lot of attention right now for the possible increase in socioeconomic differences because of this pandemic. And I think this attention could ensure that there is also more policy attention for this group and that action will be taken. And I want to also give a research recommendation. If we want to know the true socioeconomic impact of the COVID-19 pandemic, then we need inclusive research. So we need to make sure that people with a low income, with low educational level, from all different levels of the population are included in research. And I see a lot of things on my LinkedIn and on other places with a call to action like join in this research, fill in this questionnaire, which is nice that people are doing research. But if you do it like that and you don't know whether you're including everyone in your research, then you won't know what the impact will be on the most vulnerable people of the population. So now we have time for questions, and I also want to thank my colleague Thomas Martinelli for his help with preparing this lecture. And I have a final menti.com question for you, and you can maybe fill it out during the questions or just join in the questions, whatever you want. But I would like to know what you've learned from this lecture. So you can type it in here, or we can just go to the questions.
Gera, thank you very much. Who would like to start with asking a question to Gera? You have to type your name so we can unlock you. Well, they're still typing, I think. I was wondering, because I read somewhere that smoking was had a protecting effect on COVID-19. Is that already tegengesproken?
Yeah. Yeah, there are some stories or also some data showing that people who smoke are less vulnerable to getting the disease. And what I showed was the severity of the disease. And getting the disease, that's probably because of, I don't know really a lot about the specifics of this, but it's about selection effects of who participates in the research. So yeah, those were very early studies, and people may have been selected that were on the ICs, for example, who were hospitalized, and maybe the people who had the severest COVID-19 didn't get any hospitalization, for example. So there are many explanations for this difference, but you should quit smoking if you're doing that right now, because it makes the disease less severe.
Okay, thank you. Okan, I unmuted you, you can ask your question.
Yeah, hello. Well, I was wondering, because I watched the news today and I saw that the crystal meth labs in the Netherlands have increased to, I don't know the exact number, but it increased a lot. And I was wondering what would happen in combination with this crisis and the fact that you have all these cartels who are now dealing in crystal meth, which is quite a hard drug. So will people go and use more crystal meth now, and will that become a really big epidemic that you also have in the United States, or won't it be such a big problem here?
Yeah, good question. Thank you. It's very hard for me to look into the future, of course, but I think probably people who use other drugs but cannot get these drugs right now will turn to crystal meth instead, because it can be produced in the Netherlands, and other drugs that they are reliant on getting it from Eastern countries, for example, and that cannot get to the Netherlands. They cannot use those drugs right now, so they would turn to something else. So then it would not be, it would just be a displacement of using a different type of drugs, and not really an increase.
Okay.
But yeah, it could be that people who are stressed or depressed, that they try, or bored, try some things like that. Of course, that's a possibility. Yeah, and like I said, there are certain groups that are more at risk for this. I hope there will not be an epidemic like you're saying. Yeah.
Okay, thank you.
Thank you, Okan. And then Judith, you can ask your question. Judith asked if you could elaborate more on the government's strategy to address this problem, and then not just the research need, but more on the strategies.
So whether we do a lockdown or not, or things like that, or yeah, you probably don't know either because you're just reading the question.
Yeah, her audio doesn't work. Is that
okay?
Correct, Judith?
Or maybe to reduce socioeconomic disparities in general. That may be also something interesting to reflect on.
Mm-hmm. Yeah. So starting with the pandemic, I've shown 3 different things: the disease, the measures, and the economic recession. Some people have argued that a lockdown is not a good thing because it will increase an economic recession. But it's very difficult for me as a public health researcher to say what governments should do. And I think in the end, the socioeconomic impact of the different choices that governments make, we can see that in 10 or 20 years what the real impact would be, and I'm not comfortable really about advising about that. And then in general, what you could do to reduce socioeconomic differences is really help people who struggle and who have less money, and give them income support, and still give them their paycheck if they're sick, which is a very important thing that I told. Yeah, and really use a combination of education and helping people is what is important.
What I will do is I will add 2 reports into the chat of WHO and PAO commissions, and it includes a very detailed discussion about what government policies can be put in place to address the social disparities and social determinants.
And then Robert had maybe a really personal question, but I don't know. Robert, can you ask your question?
Yeah, I know it's a bit controversial, but yeah, I was wondering what your, because we were talking about that people might use more crystal meth. What is your opinion of like the treatment of these people? Should drugs be legalized for them in a way so they can be helped in that sense?
Yeah, it's an important question. Well, I'm a researcher, so not making these decisions, of course. Yeah, I think people need to be helped, of course. And for some people, a way to help them is to give them drugs or substitutes for drugs. And then during the help they get, they can reduce this use or go to products that are less harmful. So I think that's a good thing to do. And the worst thing you can do is just turn your back on people and say, well, you're using something that I don't like, so I don't help you.
Thank you. And Sam also has a question. Oh, sorry, Sam first and then Nastya. Sam. Yeah, Sam.
Yeah. Yes, my question was, what do you think the impact of this COVID-19 pandemic is for people who are being treated for their addiction? Because I don't know if I'm correct, but it seems like you're mainly talking about people who aren't being treated, and for them the impact is quite negative. Mm-hmm. And I was wondering what it would be like for people who are being treated, because I can imagine that maybe this whole situation might make it easier for them.
Yeah, so you mean because there are less situations in which you can use. Yeah, that's a good one. I think especially for people with an alcohol addiction, well, some parts of what is happening right now would be easier for them. And actually, we've just submitted a grant proposal to, we have a cohort of people who are in recovery from addiction. And we want to follow up with them during this pandemic and see what happens to them if they are having more trouble right now or not, or what's happening with them. So we don't know the real answer yet. But I think you're right that for some, it might have good aspects, but also because of the isolation, the boredom that you might experience with being at home all the time, stress and fear and anxiety, it could also have a negative impact for these people. So it's important that they still receive help. And a lot of services have gone online, and also peer programs where people help each other, which is normally done in a face-to-face group. a lot of those are going online too.
Okay. Okay, thank you.
Thank you. And then Naistia also has a question.
Yeah, thank you. You mentioned that some countries try to address the alcohol problem by limiting the accessibility or availability of alcohol. That was also mentioned in one of the articles that we had to read. Would something like that even be possible in Western countries where alcohol is very socially accepted and is even like a means to express one's culture?
Of course, it's possible in countries like the Netherlands, for example, but I don't think it would happen that soon. I think it happened in countries where there were lists of things that were essential goods. So vegetables, fruits, the really important things like food and water. You need those, and then alcohol is not one of them. In the Netherlands and in many other countries, you can still buy whatever you want and go to shops. So then it would not be very logical to ban alcohol right now. Then it would just be something that politicians would want to do, and they just grab this opportunity. But you're right that alcohol is so socially accepted in our culture that it would be strange to. It would probably not be something politicians would do in our culture.
Are there any other questions? Maybe Gera, you want to respond to the last Mentimeter question?
Yeah, I see that 14 people have given some answers. Yeah, I like that people, a lot of people say something about the mechanisms that they found them useful, which is also something that I like the most about my research, is going into depth of why things are happening and not only what is happening. Well, compliments about my PowerPoint slides, also nice. Socioeconomic impact, correlations. Yeah, glad that people learn things and that they liked the overview.
Is there anyone who wants to ask one more question to Gera, or otherwise we'll close this meeting? Okay, then I really, really would like to thank you, Gera. Maybe everybody can say a thank you in the chat. And then Gera, you should now watch the chat because everybody is thanking you.
Okay, well, thank you for listening. It was very nice to do this.